Okay, let me tell you. Yes, for me, that's excellent. Yes, Nayab, that's a good answer. Kiran, yes, for anesthesia, yes, for some anesthesia blocks, we should be knowing the anatomy and the nerve innervation. However, classically, when we talk about the urogynecology, the innervation is important because that might lead to incontinence. And yes, sometimes there, due to any traumatic history, due to bad obstetric history, they could be prolapse and something, some pathologies like that comes from this region. So that's why this is very important module for your exam. Then the second part, which mentions mechanism of continence and micturition and the principles of pelvic support. Now here you need to cover the physiology of micturition, which covers your subject physiology. Then congenital anomalies, pregnancy, childbirth disease, estrogen deficiency affects these mechanisms, like in postmenopausal women. Due to decreased estrogen level, that might lead to urinary incontinence as well. And the congenital anomalies, as far as they are concerned, you will cover these under embryology. Then the principles underlying the treatment of bladder and pelvic floor problems and the impact of the other drugs on the bladder function. So this is classically your topic which covers, this is the information which covers your topic of urinary incontinence. So today we are going to focus on the point number 4 from the knowledge area 15 of the RCG curriculum. Am I clear so far? Okay, that's good. Okay, so why I have added the slide of the RCG curriculum so that it could help you to prepare in a better way, and you should prepare your exam in a very strategic way and in a focused way. So don't waste your time. This is a tip for your MRCG one exam. Please do not waste your time on extra reading extra information. Try to be focused and try to follow the RCG curriculum. It would save a lot of your time and energy. Okay, so let's begin urinary incontinence in women. What is urinary incontinence? Simply, whenever you read the word urinary incontinence, that means any involuntary leakage of the urine. That's it. This is the simplest definition of urinary incontinence. In patients, particularly in the UK, these are the demographs from the UK. In patients more than 70 years of age, around 20% of women uh, and 10% of men experienced an episode of urinary incontinence in their preceding month. So that's a huge issue. If we look at the biostats in the UK, urinary incontinence is quite common. So that's why this topic holds a significance in your curriculum. The second thing, the types of urinary incontinence. So what happens now? We know urinary incontinence is the abnormal leaking of the urine, but what causes that? So there might be a problem in the maybe in the sphincter of the urethra that is not able to hold the urine tightly. There might be problem with the detrusor muscle itself. There might be the problem with the nerve innervation of the bladder or the urethral sphincter. So there could be any cause. And according to that cause, we divided different types of urinary incontinence. So mainly, we have 7 classifications. For your exam, if since this exam is classically focused on the women health, so we will focus on the types of urinary incontinence, which are way more common in the females. So classically in your exam, if I talk about the MRCG1 curriculum, they test you on the knowledge of stress incontinence and urge incontinence. And sometimes you will get a question on mixed incontinence. So let me give you a brief. Uh, just make your mind like what type of question you are gonna get in the exam. So first category is the diagnostic question. What that mean? They might give you a scenario, a clinical scenario. in which they have mentioned a patient who presented with the classical A, B, and C symptoms. Now they directly ask you what type of continence this patient might have. So this is your first category of questions. And for that, you should be knowing the definitions of different types of incontinence. If you know the definitions, if you know the basic differences, then these questions are very easy for you. The second category of the questions you might have, they maybe ask you about the management. So the management, they classically ask you the management of maybe stress incontinence or urge incontinence. So these two types are very, very important for your exam. Then the third types of question, they might ask you about the side effects or mechanism of action of different drugs which we used in the management of urinary incontinence. That's it. So is everyone following me?
पहले कितने दे रहे थे? 15 में ले आते हैं। पहले कितने हम दे रहे थे? 25। 15 में वो क्यों आएगी? वो नहीं कोई और 15 में ले आते हैं।
Could you please your mic?
मैं ये 15,000 में देख के आते हैं। एक 15 चाहिए।
Okay, give me a second.
बात कर चुकी। मैं देखूँ 15,000 में देख के।
Okay. So is everyone clear about the types of urinary incontinence and what types of question you might encounter in your exam? If you want me to repeat anything, I can repeat. Okay, so let's begin from the stress incontinence. Just try to break down the word stress incontinence. That means something is stressing over the bladder. So what is stress incontinence? It is a small amount of urine is leaked following increase in the intra-abdominal pressure, such as coughing, exercise due to inadequate sphincter. So please try to memorize. If in the exam they will directly ask you the pathophysiology of stress incontinence, the second word that would come to your mind is the inadequate sphincter. And what is the first word that should come to your mind? The simple definition of stress incontinence. Whenever you see the word stress incontinence, the first thing that should become into your mind is that increased intra-abdominal pressure. That means in your SBA, the clinical scenario, the patient might be presenting with the features of leaking of the urine while or exercise. Yes.
Dr.
Okay, so the second thing that should become to your mind is the inadequate sphincter. So this is the pathophysiology. It is exclusively seen in the females and associated with parity. Now, these are the risk factors for the stress incontinence. The first thing is parity. That means the patient in your clinical scenario might be multiparous. She might have previous hysterectomy and she might be obese. And it rarely occurs in the males. So it is classically the pathology of the females, and that's why in your exam they love to question you about the stress incontinence. The second is urge incontinence. This is also very common in the UK. What happens try to understand the urge incontinence. If we understand the things logically, then there is no need to revise this topic. Okay, so in urge incontinence, the sudden sensation of bladder fullness and the need to pass urine caused by intermittent strong bladder contractions. Now the pathology is within the detrusor muscle. The detrusor muscle might be overactive. It might be which leads to the urinary urgency. So in this type of questions, they usually say the patient has increased urgency, and they usually leak urine when they even before reaching to the washroom. So this type of clinical scenario is very classical for urge incontinence. Whereas if we compare with the stress incontinence, in this SPA, the patient have leaking of urine with the coughing, laughing, or maybe during exercise. Whereas in urgent incontinence, this is not the case. This patient has urgency maybe all the time. They have a sensation of bladder fullness, and they usually leak the urine before reaching to the washroom. Is everyone clear about the stress and urgent incontinence? Because they are very important, and you will get the questions from these types of incontinence. The rest one are simple. Then the third category is mixed incontinence. It is a mixture of, in this type of clinical scenario, your patient may present with the leaking of urine with coughing or exercise. Along with that, the patient also complains about, I usually leak the urine before reaching out to the washroom. So whenever you will see both the symptoms of stress and incontinence together in your clinical scenario, your diagnosis would be mixed incontinence, and that's simple. Then we have overflow incontinence. In overflow incontinence, it is a continuous or frequent loss of small amount of urine as a complication of chronic urinary retentions occurs when the bladder cannot be emptied completely, and it is classically seen in the males, especially the males who have BPH. Then we have continuous incontinence. In continuous incontinence, there is a constant urine leaking and the person is wet all the time, and it is really, really miserable for the patient. And this classically happens maybe there is any fistula. Sometimes the patients who have bad obstetric history and they later develop fistula, and especially the vesico-vaginal fistula. So what happens in those cases, the urine from the bladder continuously leaks out from the vagina. So this might be a cause for continuous incontinence. Then we have functional incontinence. They rarely ask you a question from functional incontinence. This is just for your information. A loose term to group together external factors that lead to incontinence. For example, mobility impairment, higher cortical dysfunction such as frontal lobe disinhibition and apraxia. So functional incontinence usually happens in the old age patients, the patients who have dementia, the patients who have any past history of stroke. So these may be the patient who have low pressure hydrocephalus. So these patients might have functional incontinence. Then the last one is situational incontinence, which is not pathological at all. If someone have just presented with one episode of incontinence, maybe due to during sexual intercourse or giggling, do not label that patient with any pathological incontinence. That's a situational thing. So we have done with the types of urinary incontinence. If anyone have any question, you may ask me. Otherwise, I will move on to the next slide. Okay, the main difference between 4 and 5 is that in 4, there might be episodic leaking of urine because the patient is not able to empty their bladder completely. These type of patients may have urinary retention, and why that happens due to urinary outflow obstruction. For example, the males who have benign prostatic hyperplasia. So what happens that BPH causes the outflow obstruction of the urine, and as a result of that, the patient have incomplete emptying of the bladder, which later on leaks on and off. Whereas in continuous incontinence, the patient is wetting all the time. The urine is leaking all the time. Dr. Niab, are you clear now? Okay. Now the next question. Let's take this clinically. Like you have a patient that comes to your clinic and she might be presented with the symptoms of stress incontinence or urgent incontinence. Now you have successfully diagnosed your patient, but now what you are going to do with that patient? So first thing, you should be able to assess your patient on the basis of her symptoms and try to evaluate what types of urinary incontinence your patient have and how you're going to manage your patient. So there are simple steps, and literally these are the clinical steps, but the same steps you may implement while solving your SPAs. So first thing first, whenever you get a clinical question, whenever you get an SPA, try to establish the type of incontinence. That is your first step. I'm repeating this again, and it is worth repeating. Whenever you get a question from urinary incontinence in your exam, always establish the type of incontinence. And that is the reason I spend too much time on explaining the types of incontinence. So let me repeat, incontinence occurring when coughing, sneezing, lifting, or exercising, it is stress incontinence. Or if sudden urgency, frequency, nocturia, that means it is urgent incontinence associated with overactive bladder. Rarely, if not characterized by either of the above, ask about voiding difficulty, hesitancy, straining to void, poor or intermittent urinary stream, and recurrent dribbling of incontinence, just to rule out overflow incontinence, which is classically happens in the male patients. In the females, you will get the more questions from stress and urgent incontinence. Yes, if the patient complains of constant passive leaking of urine, that means there might be some vesicovaginal fistula is there. Okay, so once you establish the type of incontinence, the second step is what is the underlying cause and what are the contributing factors in your patient. So what could be the causes? There might be some drugs like diuretics. Ask about the previous investigation, treatment, UTI, low spinal surgeries, prolapse, hysterectomy, anorectal problems, and obstetric history. Since I have taken these references from the guidelines, I just try to implement this on your SPAs. What happens, the underlying cause and contributing factors, maybe they will give you the reports or some investigations in your SPA. So that's the second point you need to focus on. Okay, whenever, this is a tip, whenever the patient have any neurological problem, like multiple sclerosis, or the patient have any spinal cord injury in the past, and the patient may have any chronic urinary retention, so your diagnosis would be more on the side of overflow incontinence. And yes, there are some systemic diseases which leads to incontinence like heart failure, diabetes mellitus. Okay, so the third thing, now you know your type of incontinence, and now you know the risk factors or the contributing factor. But the third and the foremost thing is assess the severity of the symptoms. And for the assessment of the severity, we usually give the patients the bladder diary for the 3 days. And in your exam, particularly in the module of data interpretation, you might get a bladder diary and they will ask you to interpret that. Is everyone with me? The bladder diary, this is a topic which many students ask me to give a lecture on. So please try to have a good concept here. What is bladder diary and why we are using that? So we are using bladder diary whenever the patient comes to in our clinic with symptoms of urinary incontinence. We usually give them the bladder diary to assess the severity of the symptoms and to establish the diagnosis. Okay, I have shared the link here, the bladder diary which is used in the NHS. It consists of 3 pages, and we ask the patient to maintain that for a minimum of 3 days, and after 3 days she need to come back to the clinic, and then we will assess her the bladder routine. So it includes the types of fluid drunk, individual voided volume, frequency of micturition, episodes of urgency, episodes of incontinence, and pad and clothing changes. So if you want to look at the bladder diary, you can simply go, type on the Google that bladder diary, which is used in the NHS, you will get a link. Okay, so the next thing is the management of urinary incontinence. First thing first, we always advise the patient to do some lifestyle modification. And what are those? Is the reduced caffeine intake, because caffeine might irritate. It works as a diuretic, and also it sometimes it irritates the detrusor muscle. Then fluid intake. Avoid drinking either excessive or reduced amount, because decreased fluid intake may worsen or cause constipation. Recommend daily intake 6 to 8 glasses of water. Weight loss if BMI is more than 30. Smoking cessation. Now let's discuss the management of the stress incontinence. Please do let me know in the chat box what is stress incontinence. Please write in the chat box what is stress incontinence. Yes, Dr. Humera, that's excellent. I just want to assess your understanding. Okay, so Dr. Humera said leaking of urine due to stress like cough. Okay, Dr. Nayab said leak of urine due to raised intra-abdominal pressure because of inadequate sphincter. Yes, that's a way more precise definition. Now, this patient you need to manage. How you're going to manage stress incontinence. So the first line is pelvic floor muscle training. We usually refer the supervised pelvic floor muscle training to an appropriate practitioner, maybe a women's health physiotherapist, urogyne nurse, or continence advisor. Then pelvic floor muscle training is an individualized program that ideally lasts more than 3 months and continued if beneficial. The minimum of 8 pelvic floor muscle contractions are needed more than 3 times a day. If conservative treatment fail or if patient wants further management, then consider referral depending on local service provision. And duloxetine is a second-line treatment, but only if the patient prefers drugs to the surgical treatment or if the surgical treatment is not suitable. Am I clear so far? The important thing to remember here, the first line management of stress incontinence, it is always pelvic floor muscle training, in which minimum of 8 pelvic floor muscle contractions are needed more than 3 times a day. And it is continued mostly more than 3 months of time. Then we have the urge incontinence. For the urge incontinence, please do let me know what is urge incontinence. My question is, what is urge incontinence? Yes, Dr. Humera, that's perfect. Dr. Humera, according to Dr. Humera, urgency frequency of passing urine due to overactive bladder. And according to Dr. Nayab, it is overactive bladder leads to leak of the urine before going to the washroom as patient has sensation of fullness. That's perfect. And Dr. Watt said pass urine before each bathroom. Yes, that's accurate. These are the lines that would straightly land to the diagnosis. Okay, so now how you're going to manage urge incontinence. Let's imagine you get a question on urge incontinence, and now you are successfully able to diagnose the type of incontinence. They might directly ask you, what is the first line management for this patient? So the first line management for the urge incontinence is a bladder training because the problem is with the detrusor muscle. It is done for at least 6 weeks. If the symptoms persist and frequency is troublesome, then consider anticholinergic drugs like oxybutynin. We have different options. Try to have a read on all types of drugs. Maybe in your exam, they won't give you the option of oxybutynin. They might give you tolterodine. So that's why you need to have a good knowledge of all the drugs. So these are the 3 drugs which are used as a first line medical management for urge incontinence. And these are anticholinergic drugs. Okay, do not offer immediate release oxybutynin to the frail older patients because that might lead to confusion. The next drug we have is the myrabegron. When you are going to offer myrabegron, when the anticholinergics are contraindicated. So one question in the recall, which is I have seen this question repeating so many times, that they ask about the mechanism of action of myrabegron. Anyone out there who know what is myrabegron? When you start solving the past equals, you will see this drug. They repeatedly ask about the mechanism of action of myrabegron. Okay, so let me tell you. Myrabegron is a beta-3 receptor agonist, which will cause detrusor muscle relaxation. It classically works on the detrusor muscle on the beta-3 receptor and causes the relaxation of the detrusor muscle and leads to relief of the urge incontinence symptoms. Am I clear? Okay. So now you should understand the significance of physiology of micturition, because once you know the physiology of micturition, you will know what type of neuronal innervation is there, what innervating what phase of micturition is under parasympathetic control or sympathetic control or under somatic control. And yes, when you study those things, you will also see the types of receptors which are there on the detrusor muscle, on the neck of bladder, or in the urethra, or in the external or internal urinary sphincter. So that's why the physiology of micturition is very important. If you want to have a good command on urogynecology, please try to understand the topic thoroughly. Okay, so if starting drug treatment, explain the patient to take the drugs for at least 4 weeks to work. Warn them regarding the side effects like dry mouth, constipation, blood visions, because anticholinergics have these side effects. And these medicines can be continued for long term if effective. Okay, so what happens now? You have successfully give the management to your patients. Maybe they have stress incontinence, urge incontinence, or the mixed incontinence. So what would be your next step in the management is to review your patient after 4 weeks, or if the first line treatment is not effective or tolerated. So what should be your next steps in the management if your first line management fails? Then refer to the secondary care, maybe try alternative antimuscarinic drugs, myrabegron for further 4 weeks. If the patient is postmenopausal, then yes, you may offer intravaginal estrogen. If there is nocturia, then yes, sometimes you may prescribe desmopressin, which is off-label. If conservative treatment fails, consider referral to the urologist. And if in your clinical question, they give you a scenario of mixed incontinence and they ask you the management, then please go with the management on the basis of the urinary incontinence type, which is mostly dominant. For example, in the scenario of mixed incontinence, the patient has more pronounced symptoms of stress incontinence, then you are going to manage this on the basis of stress incontinence. Or if the patient have more pronounced features or symptoms of urge incontinence, then manage your patient accordingly. Okay, so this is a summary. I have made a table. If you have no time to study the topic in too much detail, or you just quickly want to revise, just have a look on this table, your topic. So here, stress incontinence, we all know that it is due to incompetent sphincter. Again, that definition, leaking of urine during activities like which involves increase in abdominal pressure, such as sneezing, coughing, laughing, cause mostly multiple vaginal deliveries. Treatment, first line is the pelvic floor exercise, and surgical is open colpo suspension. Then urge incontinence is dysdrosor, overactivity, difficulty in controlling the desire to urinate, wetting before making it to the bathroom. Causes irritated bladder by alcohol, caffeine, UTI, constipation, pregnancy, stroke, diabetes mellitus, Parkinson's, spinal cord, and nerve injury. Treatment, first line is bladder training. Second line is anticholinergic drugs like oxybutynin. After trying bladder training. Then overflow incontinence classically due to bladder outlet obstruction, and it is mainly seen in the males. Causes BPH, prostate cancer, treatment specific for BPH or intermittent catheterization. Is everyone clear? We have done with the topic. Now, if any time you want to revise the topic of incontinence, just have a look on this summary. Then there would be no need to go back into those slides. Those are just for your understanding and for your concept making. But this is the table which would help you for your exam. Okay, so one more, I wanted to add one thing. Once we are done with the bladder diary, which we do for the assessment of the severity of the symptoms and for establishing the diagnosis. There's another thing which we use, which is urodynamic testing. Is anyone have any idea what is urodynamic studies? Okay, let me tell you why we do. Yes, Dr. Mehra, that's correct. But when we offer the patient urodynamic testing, well, what happens when a patient comes to you and she or he may have the symptoms of urine incontinence, and the symptoms are quite complex. And after assessing from the bladder diary, you are not able to diagnose the patient, like what type of incontinence that patient have. So for such complex cases, when you are not able to reach to the diagnosis, you will offer the urodynamic testing. And in your exam, they might give you a cystometrogram and ask you to interpret that. Okay, is everyone ready for the SP practice? Okay, you have, how much time should I give you? You have 50 seconds to answer one question, and your time starts now. That's excellent. C is the right answer, which is pelvic floor muscle training. Okay, so this patient have the characteristic feature of stress incontinence, and the NICE suggests a trial of pelvic floor muscle exercises as the first line treatment. Here is your next question. That's correct. I have got the pretty intelligent students. Keep it up. So, yes, this patient have urge incontinence or detrusor instability. The risk factors might include multiple sclerosis, stroke, but in some cases there is no specific cause. In men, urge incontinence may be due to neurological disease or an enlarged prostate. Patient may have involuntary urine leaking, preceded by urgency of micturition. This means a sudden and compelling desire to urinate that cannot be deferred. Here is your third question. Your time starts now. That's correct. Excellent. Well done, everyone. The woman has stress incontinence. Okay, in this question, there was a typo mistake. Let me correct here. Now we are good to go. Okay, it is associated with the defect of urethral sphincter. We have literally discussing this, I think, fifth or sixth time. Now you will never forget this. Most patient complains of involuntary loss of urine on coughing or straining. It usually, the risk factors are pregnancy, labor, delivery may all cause mechanical and denervation injury to the normal supports of the bladder, neck, and proximal urethra. And it might be related to menopausal changes. Okay, if anyone have any question, you may ask me from this topic. And we have explored some important concepts today, but the journey to MRCG Part 1 success goes far beyond that. If you are looking for a structured, high-yield approach with expert support every step of the way, I warmly invite you to join the Med Institute's Premium MRCG Part 1 course. Okay, let me give you a brief how you can start your preparation. Okay, first thing first, I would give you a tip for MRCG Part 1 exam. Listen carefully. This exam is all about practicing. The more you will revise the curriculum, the more are the chances for you to pass the exam in first go. Since the part one exam is mostly involves the basic subjects like anatomy, physiology, biochemistry, biophysics, pharmacology. So these subjects, I totally understand. We study these subjects way in the beginning of our medical journey. So for the understanding of the basic concepts which are relevant for your exam, for the focused exam preparation, we usually arrange 15 interactive live sessions with schedule in which we comprehensively cover all the subjects. And we classically focus on the high yield topics which are relevant for your exam. So there is no wasting of time. Meanwhile, when we arrange the live sessions with schedule, we also provide the mini schedules on the daily basis. That means you already familiar with your daily task, and honestly, it helps the students in so many ways. It maintains a competitive environment. It maintains a healthy competition among your colleagues. By any chance, if you are not able to attend the live session, the recordings would be available on the website till the exam. So by any time, if you miss the lecture or if you forget the concept and you want to have a look again, you can simply go to the website and you can watch the recordings of that particular lecture. Then, followed by the live sessions, there are intensive discussions in the Telegram group on the daily basis, and which classically focus on the mini schedule. For example, if the task of urinary incontinence is given on a particular day, you will get a chance to practice the SPS from that particular topic on the daily basis. Then there is an updated question pool on the website in which we have with the team of experts, we have segregated all the SPAs from the recalls in the subject-wise manner. For instance, if you're going to start anatomy and you have attended the live session, you have attended the daily Telegram group discussions, then there is a chance for you to practice the past recalls from the anatomy on the website. So in this way, you will manage your exam preparation in a strategic way. Then there is a pool on the website in which all the recalls are solved. You will get the exam like papers. Then there is a special session which is classically on the biostats. By the end of each module, you will have a subject-wise mock. For instance, you have started anatomy, you have watched the live sessions, you have done the daily Telegram group discussion, you have solved the SPAs on the website, and after that, you will get a chance to solve the subject-wise mock. And now you can imagine you are literally revising all the things 5 to 6 times during your exam preparation. So do you think that if you follow this strategy, do you think is there any chance to fail the exam? Ask yourself. Then once you're done with this pattern will be followed for each module. And once we are done with all the 15 modules, then at the end we have 3 major mock exams, which are full length mocks. Then there is a comprehensive revision until the exam day. We will provide you with the updated study material. All the books, all the material, the study material which is required for the exam is uploaded on the website. Moreover, you will get 24/7 study group support. Continuous support would be provided through Facebook, WhatsApp, and Telegram. Is everyone with me? Okay, so this is an idea, this is an overview how you can begin your exam preparation. And if you need any help, any guidance, any mentorship, you are more welcome to ask any favor from us. Let me share you some the feedback from our previous batches. We have consecutive batches of 100% results in the MRCG1 exam with the very good percentages. Here you can see some happy faces. So this is something which is very rare and very overwhelming for us as well. Whenever our students they pass the exam and they share their thank you messages, this is more than enough for us. So there are a lot more happy faces, and I wish you best of luck with your exam. And I really wish all of you, once you're done with your exam, you will share the similar wishes with us. So here's a recap of our organized schedule. If you joined our premium course, what you're gonna have is the mini schedule of all the subjects, covering higher topics, interactive live sessions for all the subjects. Recording would be available till the exam, comprehensive notes, PDF of all the subjects, intensive 2-hour daily SP discussion, subject-wise recalls, year-wise recalls, all books and supplementary material, high yield revision flashcards, subject-wise mock, and RCG Pearson pattern mock exams. And yes, we are going to offer a workshop in which we practice more than 3,500 SPs, particularly the exam-like questions. And also, it includes a free biostat lecture. This is a 2-day workshop which is classically focused on the biostats. Since I understand we doctors, we are not good in maths, especially if I talk about myself, I'm very, very, very poor in maths. I hate biostats, and we totally understand that this subject is particularly challenging for the medical students. So that's why we have arranged a free biostat lecture 2-day workshop. Okay, so these are the prices for our basic. There are 3 types of packages we are going to offer. The first one is for the $99 for the independent learners who want to access to study material at their own pace. In this particular package, you just get the access of on our website. You will have all the study material, lectures, and you can study on your own. Then the second one we have the $150, which is a structured sport and subject-wise discussion, includes everything in basic plus focus mini schedules, intensive subject discussions on the Telegram on the daily basis. And then the third package we have is for the $199, in which the live sessions are included, and complete package for serious aspirants aiming for the top performance. It includes everything in gold plus free 15-day recall workshop, special statistics workshop, 3 full-length mock, and priority sport and guidance. So these are the 3 packages we are currently offer. You may choose anyone which suits you the best. So if you need more information, feel free to reach out to our customer support team. We are here to help you. And thank you so much for being with me so far. If anyone have any question, you may ask me. Yes, Nayab, you may ask.
Ma'am, I just want to ask that I asked it further from one of the mentors that for the students who are doing job and they cannot take leave. So how is it possible to prepare for the exams? Like the PDF stuff is not downloadable. So taking notes is a very long, lengthy procedure. So how should we study? Like we can take the screenshot and we spend more and more time in recalls and mock, or we have to take notes of this PDF.
Okay. I understand your question. I can totally understand from where you're coming from. Well, first thing I always reassure my students